I am Taichi Sakaguchi, the president of the Japanese Association for Minimally Invasive Cardiac Surgery, JmicsWebinar230525. I would like to express my gratitude to all of you for participating in today's webinar titled MICS in Asia. This event marks the first step of JmicsWebinar internationalization project, with the aim of sharing knowledge among neighboring Asian countries and ultimately disseminating information globally. We are honored to have distinguished mixed surgeons from China, Singapore, India, Malaysia, and Thailand joining us today. Additionally, esteemed commentators from Vietnam and the United States are joining us, adding great value to our discussions. I hope you will enjoy this webinar today. Thank you. So the Professor Sai and Professor Kikuchi, could you start?
Good evening. I'm Dora Sai and moderating this webinar together with Dr. Keita Kikuchi. We are international committee. We are grateful to 5 prominent surgeons from Asian countries. We are quite excited and hopefully collaborate for the future of our patient. So, Dr. Kikuchi, please start.
Okay. So good night. Good evening. So I would love to introduce Professor Shen Wang. Professor Wang is the Chief and Professor of Division of Cardiothoracic Surgery, Zhongshan Hospital of Fudan University. He's the President of Chinese Minimally Invasive Cardiovascular Surgery Congress, so-called CMC, and Chinese Society of Minimally Invasive Cardiovascular Surgery, so-called CMICS. And he's a member of ATS and ASCVTS and ISMICS and so on. So actually, he is a great leader of MICS in China. So please start your lecture, Professor Wang. Thank you very much.
Good evening, Dr. Sa, Dr. Sakaguchi. Thank you for inviting me to attend this conference. I want to show my screen first. Can you see?
Yes.
Okay. Okay, this is a minimally invasive in China. Right now, we know that every patient want to choose the minimally invasive, but because the technique and some equipment develop, so more and more patients want to do this. Recent 5 years in China, we can see more and more minimally invasive cardiac surgery have been carried out, but mostly the east of China. So this is last year we have some data from the CMC, that is the Chinese minimally invasive cardiac surgery complex. We can see the total number of minimally invasive is increased 30%, very fast. Not only the valve surgery, also the cardiac surgery also did TAVI, maybe 30%, cardiology 70%. And the minimally invasive, this is for the Dr. Sakaguchi technique, only increase 60%. And for the aortic valve replacement and hybrid and the congenital and MACE and so on. You can see going fast. This is a regional distribution. You can find the east of China is still is #1. North better than the south. South better than the north region. For the technique, for the minimally mitral valve repair, still we can see that top 3 hospital maybe over 300 per year. Like my hospital, Shanghai Zhongshan Hospital, is the volume is #1, and the second is Guangdong. Volume is the hospital and PIA. And for the mitral valve replacement, Zhejiang, near 200 per year. Most the technique use the endoscopy assisted light mineral sternotomy. This is the assisted, but maybe 50% the surgeon use total endoscopy to the minimally sternotomy, and a few surgeons use the robotic system to the mitral valve repair. For the aortic valve surgery, we can see the maybe it's a minimally invasive, the simple aortic. That's the aortic valve around maybe the top 3 hospital near 200 per year cases. More and more hospitals now changed from the upper sternotomy, changed to the right mineral sternotomy. This is the technique change. Next 100 cases, we use the sutureless valve. And this is some detailed data in my hospital, Shanghai Zhongshan Hospital. We changed maybe 5 years ago on the upper sternotomy, going to maybe more than 90% we use the right mineral sternotomy, and for the female maybe use the axis line, the third endoscopic space. This is the all detailed data now. Right now, maybe mostly use the right mineral sternotomy for the aortic valve replacement. You can see the patients a little bit younger. The mean age is 54, because maybe the age over 70 years old, maybe it's going to the TEMA. So this is the SAVA. We use the minimally right mineral sternotomy for the aortic valve replacement. Maybe 50% is bicuspid valve. And we use the tissue valve, 50%, and still have a mechanical valve 50%. So it's for this the right ministromy, we didn't use the endoscopy. So maybe like a routine open sternotomy. So the clamping time for aorta is only less 1 hour, 15 minutes. You can see the mortality is 0. So most patients can live only 4 days. So for the intervention, catheter valve in China is also increased very fast because the cardiologist did the TAVR, maybe total cases over 70%, but 30% cardiologist surgeon do this. So this is last year, the data, like Beijing Fuwai Hospital, it did more than 300. But I think this year, maybe double this number, going fast, because the insurance policy, more and more patients choose the top of the LG. For the TAVR, we use the products Edwards, Sapien3 and Medtronic, Evolut Pro, and a lot of kind of homemade. This is a TAVR. So this means the TAVR in the future in China may be going very fast. This is a lot of different design, the valve. Not only the AS, also AI. This is the maybe a couple of years ago with the AI, we needed to trans apex, but now we can transfemorally use the AI. This is the JWAF call by China. For the mitral TIMA transcatheter, still is a clinical trial. A lot of the products on the way, but still is a clinical trial. This is some different cases. We find for the few cases, it's a very good result, but for the mitral valve, still have some problem with the follow-up. But for the mitral valve repair for the transcatheter TIA, because the mitral clip they did, the cardiologist, they not only do the function and they now they're very interested about the degeneration MR. So it's maybe going fast, but right now it's still maybe 100 cases, but maybe increase fast. Tricuspid valve in China still have a lot of the patients needed replacement of the tricuspid. So this is a tricuspid valve called the Lux valve. Still is almost finished the clinical trial, maybe approved this year. Close to for the tricuspid. It looks good result. Another product is the K-clip. A lot of surgeons also did this. This is for tricuspid valve repair. Use the caster. This is another dragonfly for tricuspid valve. For a few hospitals, the pulmonary valve, then maybe after TOF, the surgery, they need the pulmonary valve replacement. Just gets the pulmonary valve. For the cabbage, the lots of China that did not Beijing, Xijing, and the hospital. This is follow the Dr. Sakaguchi technique. Dr. Sakaguchi did a lot of the cases for training Chinese surgeon for mixed cabbage. So it's increased. Thanks for the exploration. But not too much. Maybe can also do the caster, use the ablation more. So summary for the minimally invasive cardiac surgery, the patient want to do this, and the technique, especially the young surgeon, well interested about this technique. So in China, it's going fast. Not only the valve, and also in the cabbage and atrial fibrillation, and also the caster valve, and so on. So for the Jmics, the Chinese, the minimally invasive society have an annual meeting every year. And so this year, October, the Hangzhou will be the CMC weeks, maybe with more than 70 cases, the live case to show. So welcome all of you. Have time to come to China to attending this CMC 2023. Thank you very much.
Thank you very much, Professor Wang. Excellent presentation. So we would like to have some question and comment. Any question or comment? Yes, Professor Sakaguchi, please.
Professor Wang, thank you very much for the excellent lectures. It was very interesting to know how the mixing is spreading in the big country like China. And I think, do you know what is the percentage or ratio of the minimally invasive approach compared to the standard sternotomy approach, especially in the valve surgery for mitral in China?
Yes, the total is only 20% for the minimally invasive.
30%.
Because this is a different hospital have a different the word like for example in my hospital for the single valve surgery, maybe 90% use minimally invasive. But some the hospital they didn't do this.
So there is a big differences between the hospital. Some hospital, especially in the big city hospital, that they are doing a lot of the minimal invasive surgery. But especially for the rural area, they don't do minimal invasive surgery.
Yes, because this is this is teamwork. If some of the team is going, everything is normal, they like to do this because minimally invasive, the first they take long time. So some surgeons like to do this, but recent 5 years, it's going fast. The number is going fast. 70% increase.
Okay,
every year.
And do you get any incentive or a financial incentive or the reimbursement by doing a minimally invasive approach?
Because it's maybe every patient right now, every patient that want to do minimally invasive, but the surgeon can choice because maybe ultimately they need the cabbage, both the valve and the cabbage, not the simple surgery.
Okay, thank you.
Thank you very much. So, any comment?
Maybe just short comment.
Professor Sai,
Professor
please.
Wang, that was excellent present. Thank you very much for the first speaker. That was excellent. Just one simple question. China is far more larger than Japan. Are there any strategy to propagate, to make this technically demanding things to propagate to the other hospital? Zhongshan Hospital is the top, we recognize, no question. But you have also the initiative to educate, train that standard surgeon. Would you comment for that, for just briefly?
Yes, the minimally invasive the need the technique share. So maybe every month we have some that cause the COE course. Not like last week the annual say was the COE course in my hospital. We show the live case. All hundreds the surgeon come to the hospital to visit the surgeon to do. Like Dr. Sakaguchi, they did the miscarriage hand by hand. So we learn a lot. Maybe, yes, this means the minimal invasive the technique need the share, need the learning curve, need the teamwork to work together to improve everything.
Thank you. Congratulations on fine result, and we're expecting you to more just propagate these kind of things.
Thank you. Welcome to Japan again.
So, I'd love to introduce Professor Yugal Mishara, my friend. Professor Yugal Mishara is the Chief of Clinical Service, Head of Cardiac Science, and Chief Cardiovascular Surgeon at Manipal Hospital. And he's the President of Society of Minimally Invasive Cardiovascular and Thoracic Surgeons of India, and past President, Indian Association of Cardiovascular Thoracic Surgeons of India. So Dr. Mishara performed more than 23,000 open heart surgeries which include minimally invasive cardiac surgery and robotic surgery as well. He's one of the pioneers of mixed CABG, such as total arterial revascularization, minimally invasive coronary, minimally invasive CABG on beating heart, and Da Vinci assisted CABG as well. So he's great leader of mix in India. So please start your lecture, Professor Yugal.
Thank you, Kita. Let me first of all share my slides.
Please.
And then I will really like to thank Professor Sakaguchi, the president of Japanese Association of Minimally Invasive Cardiac Surgery, and the friends like Tohuru, who is sitting here. They all are dear friends. I heard just great presentation from Professor Kofidis, who is leading in this field in this region. So I really appreciate Professor Kofidis' initiative, and I think he's absolutely right that in Asia we should have some form of cohesion between the different nations and societies, so that we can evolve something very credible guidelines and move on. So I was being asked to talk about what is the status of minimally invasive cardiac surgery in India. India is a big country, and we are fortunate that we start very early on in this field. I started minimal access, the CABG, which is mid-cab, somewhere in 97. And we got the first robot in Asia in 2002. So I started very early on, and that's how we could able to move on. And we have seen good and bad in this field. So with our experience, we can today comment what is eventually going to take the lead in our regions. Now, if you see the India in 4 regions, the north, we do around 30 to 35% of the minimal access surgery of the total of Indian volume. The south goes somewhere 25 to 30%. The west goes around 20 to 25%. East is lagging behind a little bit. I am sure that in coming future, they will take a lead in this area. Now, we in India have around 700 cardiac centers so far. And out of those 700 centers, around 20%, which is around 150 centers, are doing some form of minimally invasive cardiac surgery. Now, if you see the disease-wise, so the coronary, around 5 to 7% of the total volume is minimal access. The valvular, around 15 to 20%. And of course, congenital, which is also picking up somewhere in 5 to 7%. And mostly in the congenital, this is AST. We all know that we can perform this surgery in various ways by partial hysterectomy or thoracotomy. Same is in India. We are moving on. Everybody knows the advantage and disadvantage. I'm not going to talk about, but yes, every candidate is a candidate for mixed surgery. We all know that this is not, and we have to evaluate properly to reach to conclusion that this particular patient is a suitable candidate, and we are going to give best result out of that. The various kind of surgeries which taken in India, the mitral valve repair and replacement, the tricuspid valve repair and replacement, along with mitral valve, are some other lesions. ASD closure, little myxoma is growing up. Aortic valve, as Professor Kofidis has just enumerated, we actually started with upper partial sternotomy. I'll show you how we do that. And of course, CABG, we are taking a lead in this area because we do in a big way beating heart coronary artery surgery. So that now a lot of centers are now transforming to the mixed CABG. Now we have to evaluate properly, and we don't have access to the hologram, but we definitely do a preoperative transthoracic echo. We do CT scan in each and every case, and if need arise, we can do a contrast CT as well, particularly in the aortic and in CABG areas. Now, we always caution our students and the younger surgeons when we conduct these courses, that we must be careful about these kind of patients and these kind of anatomies. Various hardware now is freely available. Initially, early days we had issues, but now in India also, as rest of the Asian countries, we have almost every hardware which is available except Indo-balloon, which we don't have access so far. These instruments are available, and there are various companies which are now providing, and we can pick and choose which kind of instrument is good for cabbage, for aortic, for mitral, depending on their cost and the kind of, the ease of using them. Anesthesia is very important, and anesthetic is always part and parcel when we take any decision to do this kind of surgery in any particular patients. We always reassure that our femoral area is exposed because we don't know. And of course, the full chest has to be exposed because we never know in which point of time we have to convert that patient to midline stenotomy, or we can go and put patient fem bypass. Now, various cannula strategies as usual. Now, we always try to expose femoral artery and vein before going to the thoracotomy. Like in this particular case, we try to avoid any too much dissection because a lot of Indian patients, they have lymph nodes in this area. And if we excise those lymph nodes, we'll end up in a lymphoria. So initial days, we used to be very aggressive, used to loop around these vessels. Now we have stopped that. We just expose anterior surface of the femoral artery and vein and just stop there, then take pusting and cannulate eventually. So before giving heparin, then we go to do the thoracotomy like in this particular case. Now the role of TE is very, very important for cannulation, for evaluating the any lesions. And of course, this we call third eye of a surgeon, and we rely too much intraoperatively on transesophageal echo. Like in this particular case, we see the passage, the passage of venous cannulae, which is going through from IVC to the right atrial cavity to the SVC. So this is really a tool which gives us, and most important that our anesthesiologists, they can easily learn about this. And we in our country conducts the training for anesthetists who are going to venture into the minimal access anesthesia to learn about transesophageal echo, and they are now really picking up. Now, various complications can occur. One has to be very careful, maybe local. So one must evaluate the femoral vessels very nicely and avoid those complications. Yes, the vascular systemic complication, which is disastrous, and one has to be in my 28, around 3,000 cases. I was lucky that we did not have any aortic dissection. Not that we are a great surgeon, because our patients' population is young, as unlikely the Western population, where they are much, much older and have a lot of peripheral vascular disease. In India, we usually in valvular segment, we deal rheumatic patients who are much, much younger, and we usually evaluate forehand the femoral vessels, and we try to avoid that. Then one can, choose various kinds of tool, cannulation and everything. There are some do's and don't. We all know that. I'm not going to go. But I just want to address three things, which is very, very important when we are going to venture out to the minimal access cardiac surgery. One, which is very important, is cardiac standstill and myocardial preservation. One has to venture it out early on and know how to cannulate femoral arteries, vein, and how to clamp the aorta and try to avoid any kinds of complication. Then access to the surgical site, which is deep down, and of course visualization, which is really, really most important. So the minimal access surgery is an approach. The most important is intracardiac surgery or coronary artery. Master that before entering into the approach. This is just approach. So most important thing is that we have to get appropriate desired result. Maybe the same as conventional or maybe better. Now the access, we have, the two very important things, which is instruments and specialized cannulas. These are various incisions. Now, we usually, in my practice, we use centrifugal pump, but a lot of centers in India are using vacuum assist. Mostly they are using, but we are very comfortable since last 20 years we are using a centrifugal, so that we are continuing with that. Cardioplegia, depending on various centers. Now, a lot of centers are using either the del nido, or sometime the surgery is planned, they may use some custodial or some other kind of cardioplegia. Now, the valve replacement is standard practice, which is same as we do with open surgery, and that's the individual center's choice. Like, this is a classic view of a mitral valve surgery. In this particular case, we are doing mitral valve repair. This is a kind of setup which most of the center in our country are using. And let me confess that most of the center in India are using direct vision. There are very few centers where they use endoscopic or robotic. In our center, we do everything. We use direct open like this. We use endoscope, and we also use robotic tools to do the mitral valve surgery and other surgery. So this is a classic kind of the platform which most of the centers in India are using, and mostly this is direct vision. We published very early on in 2002 our initial result of minimal invasive mitral valve surgery. Now, the aortic, we started early with upper partial sternotomy, which was around 2003-04, and used to make a J on the right side, and used to have, this was the reason because we wanted to first master, and particularly we started the aortic stenosis where the heart was hypertrophic, and initial stages, maybe because of inappropriate cardioplegia, we had some ventricular fibrillation when we are closing the, the wound. So we started converting those things in initial stage, and once we master the technique, then we move to, thoracotomy, like in this particular case, exposing the femoral vessels, then going into the second intercostal space. Now, usually we, do the pre-op CT scan to see the position of aorta, how much deep is, and if it is nice, we always try to teach. Now we have mastered the technique. We can go in any position of the aorta, but in our early days, we used to take a view and see that our aortic projection is more towards the right side, and that's ideal patients for right anterior thoracotomy. Now, yes, we started using a lot of, coronars, and that's make our life much easier. After, giving heparin, doing femoral vessel scanlation, we enter into the thoracotomy area. We use a flexible clamp, like in this particular case. Some of the center, they don't have flexible clamp, so they use a conventional clamp, which is available. But in our practice, we always try to use these kind of tools, which really we have in our custody. Now, the philosophy is that this is heart and this is aortic area. When we have to deal with aorta, why to expose whole the heart? That's why this is really sensible to do either upper partial sternotomy or thoracotomy to tackle with aortic valve disease. And we now, some of the center in India started venturing into the Bental procedure, or even, some of the centers they started doing now, even arch, hemi-arch particularly. So experience is moving on and giving us opportunity to move on and do more and more complex surgeries with these kind of approaches. Daring, we all know. Now the coronary surgery is really, and I pay my gratitude to Kita. He has shown, I remember that Professor Kofidis came in our first annual meeting of the Society of Minimally Invasive in Delhi, and Kita came to Jaipur in our second meeting, and he has shown his technique of dissecting the mammary artery. A lot of surgeons in country have grabbed that opportunity. We started early on, I just mentioned in 1997 when we were doing mid-cap, and then we got a robot in 2002, and then we started dissecting the Lima and Rima with a robot, started doing Lima, Rima, Y, and moved on. Now this is a classic incision which we make for mixed cabbage. These are the tools by which you can see, these are the cartoons which shows how to dissect the mammary artery. Here we can see this in this particular case. Here we are just dissecting the internal mammary artery by open approach. here you can see that. Anyway, so video is not working. So this
Is something wrong?
This is technology support, Park speaking. Maybe as a lack of some internet speeding. So maybe Dr. Mishra, I think it need some restart of the computer. So I will technical support will call him by mobile phone. So it takes just 3 minutes, please.
So Dr. Kikuchi,
Yes.
yeah, I think it happens every once in a while in the Zoom conference.
Yeah.
I think it's a good time for the introduce Dr. Nuttapam. Can you hear me? Are you enjoying Dr. Kitamura? And
Absolutely.
I think we can just free discuss for a few minutes. Is Dr. Dean is around? I don't see his face. And also the other two young presenter from Malaysia, Dr. Sharul and Dr. Shyam. Would you guys just give some comment for the former presentation or any?
Good evening. Can you hear me?
Dr. Shyam, good night.
Yeah.
Yes.
Good evening. My great pleasure to be here. I'm enjoying Professor Mishra talk. So sorry that there's some technical problem.
I'm pretty sure he'll be back, but
yeah. He's a great surgeon. I'm seeing his technique on YouTube, and I learned a lot from him.
Are there any opportunity to having a conference with South Asian, like India or other part of the country? It is common for the Thailand or Singapore or Malaysia. I have some friends in Vietnam coming over to the Thailand or maybe Indonesia. It's communicating and also the teaching each other. Is that common in your area?
Common what? MIS?
That's
you
okay.
mean?
I mean, communicating international surgeon, is that common among the Southeast Asian countries?
Yeah, we have plenty of overseas webinar, and I think me and Dr. Natapon have joined plenty of overseas webinar before, and also on the Malaysia and Singapore surgeon, we have some activities, and I think I'll be here because of the introduction from Dr. Natapon from Lampang. He's my good friend in Thailand.
He's
I finished I finished a cardiac surgery program with him together, but not the same center, but the same year.
Okay.
Yeah.
Good.
Dr.
Dr. Natapam, please, comments.
I think it's really interesting. I think I heard that Asian or Southeast Asian start mix a long time ago with a lot of professors, but now collaboration is needed now. I think we have to find some point to collaborate. But for Southeast Asian countries, it's a struggle but because we don't have database, that is one of the most important things. Now, I just have a glance of chance, like Prof. Charu, this is going to be the next speakers. He talked to me like he have an initiative program in his mind to collect some mixed surgeons around Southeast Asians to collaborate, meeting and wet lab, dry labs, and maybe we talk about starting the database of mixed in Southeast Asians, like a small society, but I think it's going to be good. So we can have a sharing idea from him too today. That is what I think it's going to be.
Thank you, Nutapon.
Yeah, thank you for that, Dr. Nutapon. Yes, my name is Shahrul from Malaysia. Thank you for inviting me for the giving the presentation. I enjoy very much Dr. Yugra and Dr. Sophie's talk. It was very interesting talk. Yes, but what Dr. Nutapon has said that we already started some sort of small collaboration where, to be honest, we've invited Dr. Nutapon to operate in our center, and myself has operated in Dr. Nutapon center. So we're starting off slowly now, but yes, we need a stronger collaboration, which is more official to initiate and to kickstart basically MICS program in Southeast Asia. So that's in the pipeline now. So I hope it will grow in the next coming years, because I can see in India has a very strong MICS society. In fact, I've been to one of their MICS meeting, Indian Society of Minimally Invasive Cardiac Surgery, like hundreds of surgeons in those meetings. So I was really impressed. And I remember Dr. Kikuchi operated, I think, during one of the sessions. I think it was in 2018. That was good session.
Yeah, in Mumbai, right?
Yes, it was in Mumbai.
Yeah, thanks.
So I was quite inspired by that, and then that's what I'm hoping that we in Southeast Asia country can emulate in the future.
Yeah. But by the way, Mishara called me just now, and he had a technical problem with his presentation, so he want to start for the next speaker's presentation. So Professor Asai, next speaker,
Okay.
So
I think we enjoyed the free talk also. At the good introduction to the Dr. Shyam and Dr. Sharu.
Okay, just update. Dr. Mishra is now restarting still computer, but still maybe takes some time. Is
I think we can be flexible to
next
the
speaker,
next speaker to spoke. Okay, so I think it's next speaker would be, I think Nutapon briefly introduce Dr. I'm not certain I can pronounce properly. Dr. Shyam Kajaran.
Yes, Dr. Shyam Kajaran. Yes.
Shyam Kajaran. He's a young emerging star, cutting edge of minimally invasive cardiac surgery of Ramatsi Body Hospital in Bangkok. Am I right?
Yes, you're right.
He's.
Thank you.
I think we are happy to be have you, and I think it's introduced by your friend or Dr. Nutapon. We're looking forward to seeing your lecture. Are you ready for this? Please.
Yeah, I'm ready. Sure, Nutapon, please introduce me. Okay, maybe I'll start my.
You can go ahead and start, Dr. Shyam.
Sure.
You have slides?
Yes.
Yes, we can see it.
Oh, sorry.
Yes.
Okay, good evening. And thank you, JMIX, to invited me to participate this event. I'm Dr. Shyam Kajaran from Ramatipati Hospital, Mahidol University in Bangkok, Thailand. You know, Thailand is in Southeast Asia. We have around 70 million population. We are a small country. In our country, we have plenty of cardiac surgery center. 48 from public hospital. 9 of this is the residency training center, including my hospital, Ramatipati Hospital from Mahidol University. We are the residency training center. But we have plenty of center, but only 2 center can perform more than 1,000 cases cardiac surgery per year. Not my center. My center is around 500 to 600 cardiac surgery per year. And we also have private hospital that can perform cardiac surgery. Only 1 private hospital can perform more than 500 cardiac surgery a year. So this is the total number of cardiac surgery in Thailand. Before COVID time, we can perform around 16,000 cardiac surgery a year. The most operation is CABG, and the second one is valve surgery. Now we can perform around 4,000 to 5,000 isolated valve surgery. But since COVID era, the number of total surgery has decreased. I think this year, the number will be returned to normal, around a total of 15,000 cases per year. And this is my hospital, Ramatipati Hospital in Bangkok. We perform both cardiac and thoracic surgery, around 500 to 600 cardiac surgery per year, and around 200 to 300 thoracic surgery per year. And unfortunately, we don't have the official registration of the MICS in our country. I think the total number of MICS is around maybe 200 cases per year. The ratio is quite low because most of the center are starting doing MICS program. And this is my own experience. I started doing minimal invasive since 2014, and starting with the mini thoracotomy for mitral valve and mini J stenotomy for aortic valve replacement. And this table is shown my experience in minimal invasive in mitral valve. Last year, I done around 42 cases of minimal invasive mitral valve, and total number is around 220. And this is my setting. I routinely put the patient on the double lumen tube and single femoral venous drainage, except if we have the concomitant surgery for tricuspid valve or SD closure, we will put additional right internal jugular vein for SVC drainage. And we use only soft tissue retractor and no rib striator. And I don't have 3-dimension camera system, so I'll always use the 5mm 30-degree 2-dimension camera, and use flexible signet clamps and modify del Nido cardioplegia. And this is my setting. We have the main incision using only the ribs spread, not rib spreaders, just soft tissue retractor. And this is the camera port and the venting port. The operator will be here, and this is the cameraman, and our resident will sit opposite to me. At first experience, I do as beginner, general beginner. We have main incision here, and we have the camera port here, sheet boot clamp, left atrial retractor, and venting port. So I think I speak to myself, I want to reduce the number of puncture wound to reduce the invasive of the operation. By now, I only use 3 port for the general mitral valve surgery, the main incision here and camera port here, and the venting port, and for chest tube here. It served the excellent cosmetic results, especially for the female patient, because we don't have to put any puncture wound on her breast, and only the submammary incision and small port on the right side. And in some selected cases, I try to do a operation through the periareolar incision, not in everybody. In a selected patient, the thin male with the big areola, I would use this incision. And it served the excellent postoperative cosmetic result. This is 1 week after surgery, and this is 1 month. For groin cannulation, we just open the anterior part of femoral vein and artery and put the 2 purse-string suture for each vessels. No need for proximal and distal control to reduce the incidence of lymphedema. And we use the TE guide to navigate the wire before cannulate the vessel. For aortic cross clamp, we use the signet clamp and put it in the main incision and can reduce 1 puncture wound. And cardioplegia, at my first experience, I used custodial, but I had some experience of post-clamp fibrillation. The incidence is quite high, around 30 to 40%. And after my 50 case, I try modified del nido, and I prefer the modified del nido over the custodial. And now I routinely use the modified del nido for every case. And to reduce the puncture wound, I will put, after finish the first dose, I will cut the cardioplegic line and put it together into the thorax and keep it safe inside the thorax. If I need the second dose, I will remove it and can give some additional dose for the del nido, that I can reduce the number of puncture wound. And for the left atrial retractor, for left atrial retractor, I use the Professor Adam Yosu retractor from Japanese. It can put into the main incision and fix it outside. I think this retractor is more controllable than the old style one that have to be made more 1 puncture wound on the thorax. To reduce the number of puncture wound, that means reduce of pain and less pain and less blood loss, less complication. And this retractor can give you excellent exposure for the mitral valve. I'll show you my case, 83 years old female, severe mitral valve regurgitation, flail P2, simple case, LVF of 65, normal sinus rhythm. You can see the prolapsing of the P2. And you can see that there was a rupture chordae of the P2. We do the simple technique, cut the remnant of the cord. I put 2 neochordae to the anterolateral papillary muscles, 1 cord, and another cord to the posteromedial papillary muscle. I use the Superflex retractor to enhance the exposure of subvalvular apparatus. and fix the cord to the leaflet. And put the annual stitch. I prefer to use the annuloplasty band if possible, because we can reduce the number of suture and tying. And in general, we use simple knot pushing. In some case, if I want to reduce the cross clamp time, I will use the ball knot. Okay, fix the cord. And this is the final result. The incision is around 4 to 5 centimeter, 2 chest tube, 1 in the pericardial sac and 1 in thorax. And this is my short-term result. I have 212, mean age of 58, and 1/4 is rheumatic heart disease. Mitral valve replacement in 57%, and mitral replacement in 90, around 100 cases. Success repair around 84%. Cross clamp time is around 100 minutes. Bypass time 136. Conversion rate is 1.8%. We have 0.9% 30 days mortality, and 53 months of follow-up. We have 2 late non-cardiac deaths, and 1 recurrent MR need reoperation, and prostatic valve endocarditis need explantation. This is all my presentation, and I will conclude that MAS is feasible and acceptable midterm result, but in the first experience, we have to face the stiffer learning curve. We have longer cross-clamp time, bypass time, but we can serve the less operative pain and recovery time and improve the cosmetic results. Thank you.
Dr. Xian, very sophisticated, outstanding performance. I'm sorry, I should not ask your age, but let me quick question. How many years after finishing your training you started doing by yourself that's minimal invasive surgery? That system is so sophisticated. I'm very impressed.
I finished training in 2008 or 7, I think, and I start after I finished my cardiac training program. I doing the median general adult surgery. I think around 200 to 300 case per year.
Mm-hmm.
And year 7, I start doing minimally invasive program.
Year 7.
Yes.
Very impressed. I heard you are one of the most earliest adopter of minimally invasive technique in Thailand. Do you have any good teacher or trainer or somebody who stimulated you to go further? Because you're
Yes.
top down of Thailand.
I had experience in Belgium, Alts Hospital, out at
Hugo?
Yeah. I followed Professor Frank Van Praat, not Professor Hugo Vanneman. I follow Professor Frank Van Praat. But in Belgium, they always use intra-aortic balloon clamp.
Right.
But we don't have that opportunity to use that kind of instrument in Thailand because it's so expensive.
Okay.
So I have to develop my own techniques.
Mm-hmm. Thank you very much. Just one short comment from other commentator who is not commented yet. Okay. I think I personally want to ask Dr. Sakaguchi, you want to comment some? This is the outstanding performance, isn't it?
Yes, I'm very impressed, and actually, your technique is very, very similar to mine. So I think that's very impressive. Great work. Thank you.
Thank you, Dr.
Thank you.
Sakaguchi. I wanted to say that the same thing. My system is exactly identical to his. Now, the Professor Mishra is back. He's ready to continue. Dr. Mishra, you go. Are you ready to go further?
Yeah, Taru, yes, I'm
Yes.
ready, right?
Thank you for coming back.
Sorry for that there was a discontinuity in the flow, but I'll try to finish that, right?
Please do.
Yes. Right. So I left with this one. So, I just started mixed cabbage, and this is the way we dissect the internal mammary artery. When we do a direct vision, we use either the Medtronics, or now we have a phalanx detector, whatever is available. But in our country, we have all the 4 kinds of things available from the Medtronics, Thoratrac, we have phalanx, we have Gaster, and Delacroix. So we have all these 4 in various centers. And when we started a cadaveric workshop in Bangalore, and we could able to run 16 sessions and train 160 senior surgeons, the phalanx could able to partner with us, and they could able to install 100 sets across the India. So that's kind of growth, and this is one of the direct indicative that how quickly the minimal access surgery is being picked up in a country like ours. So here we in various centers, they depending on whether they are doing pedicle, thick pedicles or skeletonized. In my center, we do skeletonized memories. We also take down the rima if need arise. And now I prefer more and more robotics if we are going to take down 2 mammary arteries. Now here, I'm just showing the picture of my operating room where we are using the robotic system to take down the mammary artery, either single or double. Sometimes we take down endo-radial and use the lima and the radial to complete 3-vessel bypass. In this particular case, we are trying to expose and dissect the internal mammary artery. We are fortunate that I had mentioned that since 2002, we are using the Da Vinci 1, and eventually today we have XI system, and trying to utilize that tools to take down the mammary artery. So, this is a system which is now available in a lot of Indian centers, and at least I can claim that at least there are 10 centers across the India who are utilizing robotics to do mixed cabbage and also some of the mitral and ASTs. Now, when we are doing minimal access or mixed cabbage, we try to take down the endo vein, and this is being done by our physician assistants. They are now mastered. Now they have mastered to take down the endo-radial. In some of the cases, we also utilize, particularly the small chest patient where we are not going to get appropriate size of lima to complete 3-vessel bypass. We utilize lima and the radial. And thanks, Kita, you have shown us, with your techniques to take down. And I remember your case when you used radial to hook into the subclavian artery and carry out the bypass. This was old, and now anyway, with your different energy source, you are doing more and more lima, and radial. And in our country, we do try here. we have various systems now. Even thermo system is available in India, where we can utilize it, take down the vein and radial arteries. And our physician assistant they are really good enough to help us in this particular field. Now, this kind of, one can get this kind of radius, which is long enough to do Lima radial, triple or quadruple bypasses. Now, proximals, we believe, and initially, now we try to rely more and more of Lima Rima or Lima radial, but initial days we were hooking the vein into the ascending aorta. We use this kind of flexible clamp and do 2 to 3 proximal bypass depending on the need. And this is really very handy and gives us a good exposure and a good field to carry out the couple of proximals, like in this particular case, which we are doing. Now, this clamp is expensive and not all centers they can be able to afford. So either they can use this system or they can use another, the usual clamp and carry out depending on what is available. But in our practice, whether this was in Fortis Escort or now in Manipal Hospital, we are utilizing this flexible clamp to do a couple of. Now we have also started doing even the proximals radial into the aorta if need arise. Now we also now started using the 2 memories, like in this particular case, we try to dissect Lima and Rima and then do a Lima Rima bypass, like using a Lima Rima Y like this. And this is really one of the best operations, because the initial criticism for MICAS was that we surgeons are utilizing Lima and lot of veins, which is not appropriate. Now we across the India mastered this technique and using Lima and Rima, either direct vision or through a robotic system, we could able to do the total arterial 2 memory artery like this and carry out 2 or 3 or 4 bypasses. If there is more than that, 4 or 5, then definitely we use radial as a tool. But this is a really, I believe this is one of the very good operations, particularly the patients who have got uncontrolled diabetes, female patients, where the sternum in a diabetic situation is really a problem. If we don't touch the sternum and utilize, we all know that in our Asian subcontinent, we have a lot of patients who are young, who are diabetics, young, they require, total arterial, and we can avoid sternotomy. So this is a kind of, I should say, the tools and technique which we have in our hand, where we can give definite benefit to the patients who are young and who are having uncontrolled diabetes. Now, this is our journey. We started this is a valve segment. We started with a 10 to 12 centimeter thoracotomy. We move when we use video assistance. Our incision size goes to 4 to 6. Then if we are using video directed or robotics, our incision is much, much less. This is just working port. As Dr. Kofdis has said, we have also done some of the peri-areolar, and that's the one of the best incision, because there is no scar visible if you are giving a peri-areolar incision. And that is my incision of choice when we are using AST closure in a young male patient. Female, this is not an ideal. And for female patient, we can go to trans-axillary approach, which is also very good cosmetically. Now, these are the teams which we have trained and how we moved on in India. This is very important. In Ramaiah Cadaveric Center in Bangalore, with the help of J&J Phalanx, we rolled out 16 sessions where we did a 1.5 day training for the individuals. We usually get access to the 6 cadaver, and we could able to train. So these are some of the training sessions which we have conducted, myself and Dr. Sataki too as a proctor, and we could able to train very senior surgeons who were hesitant to start minimal access surgery. That's the very good thing, that we could able to persuade them that come on, let's try. And that's how the minimal access surgery has moved across India, from nook and corner, from south to north and from west to east. and we are still trying to do that. This is another way. We went around the world, and I myself have visited Leipzig early days. We went to some of the European center, and this is one session which I am attending with Dr. Lee in Ashram Medical Center. In his centers, we moved around the world to put our experience in the perspective to various listeners. And eventually we found what is known as Society of Minimally Invasive Cardiovascular and Thoracic Surgeons of India, where we conduct the annual meeting. This year we are going to have a 7th annual meeting in Indore on 15th, 16th, and 17th of October. Please do join. And I'm really thankful to Dr. Kofudis, who attended our first meeting, and Kita, who attended the second meeting. And I'm sure, I think Taharu has also attended one of meeting. Maybe Zoom, I suppose, 2 years back, I'm sure. Yes, I do remember. So, so this is one initiative in our part that we are trying to provide a platform where the national and international leaders showcase their technology. Industry always looking for this meeting. This is a very industry-friendly meeting. And in India, they try to showcase their newer technology, which is available to us. And that's how we are moving in this direction. We had a lot of people. Firoz, he attended a couple of meetings. Nero from Lenox Hill, Dr. Subramaniam, from a lot of people across the world, they have participated in our meeting. I'm sure this year also we are going to have one of the very good meeting, and that's going to be the one of the cleanest city of India, which is Indore, which is Tier 2 city, where we are going to have this meeting. With that, I would like to again thank and giving this opportunity, where I say that for minimal invasive cardiac surgery, we should have commitment. We must practice. We have patience and persistence to move on. Initially, we had a lot of hitch. I remember when we started mid-cap, we used to take down, remember, the just 3 segment of the mammary artery, and he used to dip into the LAD. I remember one of my case, he took a deep breath and mammary detached. Fortunately, there was no bleeding. When we did a check angiogram, mammary was just hanging and there was no flow. So those were the days when, because then at that time, we didn't have retractors. We didn't have a stabilizer. Today, we have everything. That's how we moved from those days. I'm talking of 96, 97. Today, we have tools. We have a robotic system. We have various kinds of stabilizer where we can do. And of course, we have now hybrid means of doing minimal access coronary artery revascularization. With that, thanks again for giving me this opportunity to be with you. I'm really sorry for this. There was this interruption, and that's what the technical problems. Thank you. Thanks again to the president, to Kita, to Taharu. Thanks a lot.
Thank you very much, Shigal. Excellent talk and very impressive. So, do you have any comments from audience and commentator? Professor Natapon, would you have some comment?
Thank you very much for your question to me. I'm from Lampang, Thailand. I'm the one who loves minimal invasive surgeries, but I'm just questioning about the futures and how to get the new ones to do the same as you want to do, because it's difficult in Thailand or Southeast Asian country to go out of comfort zone. And also in training system, our training system is not open-minded yet about adopting this kind of technology, even in my countries also. So it's very difficult to start. The question, who is going to start, when to start? When to start?
Let me answer. Let me answer, particularly for Thailand. I remember in 2008, I was invited in Chiang Mai, where we had a live, if you remember, if we were in that meeting. So I did a live mitral case there. and we had a presentation. And today you see, then there was only one center in Chiang Mai where they were doing some form of minimal access cardiac surgery. And today you see the Thailand where you are. So many centers now doing a minimal access surgery. Country like India, there's Fortis SCART. Then SCART used to be the center when we started in 1997. And today we have 115 centers where the minimal access surgery is being done. So this is a kind of movement. We have to convince ourselves. This makes sense to youngsters like you, or like so many who want to venture out. And that's what our commitment of society, commitment of this fraternity, who is sitting to convince you people. I remember the people always used to talk that the robotics is a future. Now we don't want to listen that. It's not a future. This is a present. Robotic is not a future. This is a present. And the minimal access surgery is the present. And in Asia, we have good substrate, which is patients.
Yeah, right.
We still have young rheumatics. Any isolated mitral valve need not to get sternotomy, or any isolated aortic valve while they get sternotomy. Or in that matter, any diabetics, young patient, why they get a sternotomy. So this is a kind of philosophy which is developed. And Thailand, to my mind, I have first-hand experience, which I visited, and I get a lot of people, they always say that Mishra, I have seen you operating there and we inspired and we are now doing this much. So that's the way to move. And you people are moving. Thanks. I had a Siam's presentation. This was eye-opening to a lot of people. And I let you know that I was invited in Professor Kofidis Center, where they started a simulation center. And they could able to roll out a center where, now see, today, modern world in 21st century, we must not talk about learning curve. No patient will allow us to do experiment and give excuse that we could able to not give appropriate result because this is a learning curve. No, we have to take a simulator, we have to go to the lab, and then perfect ourselves. In a clinical setting, we cannot say about the learning curve now. Thank you.
May I ask a question, please?
Yeah,
Yes,
okay, please.
I know the time is running out, but I just would like to ask Dr. Mishra, Dr. Sharul, Dr. Siam about the cost for the patient in your country. You know, in Japan, the patient is covered by the national health insurance system 100%, and the reimbursement which the hospital get is higher by something like $2,000 if you perform minimally invasive, but the expense for the patient is capped according to their salary. So whether they receive minimally invasive or sternotomy, they pay the same. So I just would like to know the situation in your countries.
So like India is the cheapest country for cardiac surgery. And I give you, in my practice, I get 50% of the patient overseas and 50% Indian patient. So from overseas patient, for a mixed cabbage, our hospital asks $7.5 thousand US, and for robotic assisted, $9,000 US. Okay. Now, if it is valve, minimal invasive valve, then the charges are around $9,000 US plus cost of the valve. If it is robotic mitral valve, then we charge around $12,000 US for charge of procedures, then cost of the valve over. This is a kind of, it's not like if a regular surgery like for Indian patients, in a rupees terms, if a mid-sternotomy cabbage is 4.5 lakhs Indian rupees, for a mixed cabbage, this is going to be 1 lakh extra, means 10 million rupees extra. So no, not a 10 million. So this is around say $500,000. That's the charge, which is really manage it. Same with the robot. So it's not really expensive. This is really managing. Thanks.
How about in Malaysia, Dr. Sharul?
Hi. In Malaysia, we have a government hospital, and then we have semi-government hospital, and we have private hospital. So basically, any MIS procedure will be more expensive than conventional procedure because of the cannula, mainly because of the cannula. So for fully funded patient in government setting, normally the patient doesn't have to pay extra, and there's no extra reimbursement for the doctor. For the semi-government patient, the patient might have to pay for the extra disposable, like example, the peripheral cannula. And then for the surgeon in the semi-government, again, there's no extra reimbursement. In the private setting, the cost will be more, not only for the cannula, but also for the, there's an extra charges for the surgeon. That
How
will
much?
be, I can't remember, about 15% charges extra. That if you do minimally invasive procedure. So the surgeon get extra reimbursement, and also the patient will have to bear that cost. So that's how it works in Malaysia.
What is the proportion of your private work, private practice?
Depends on the doctors. We have surgeons who work completely in the private setting, and then we have surgeons who have mixed practice, like 70% government and then 30% private.
I see. Fair enough.
Yeah, and for in Thailand, the patient have no extra charge for a patient. They can do it minimally invasively or conventional surgery for free. They only have to pay for extra instruments, such as if the patient wants to use the Inspiris or Mitris, the extra cost of the new generation valve, or for the sutureless valve, they have to co-pay for the extra cost, or TAVI valve. But the charge of the procedure is fully reimbursed by the government.
Okay, so the hospital gets more if you perform minimal invasive.
I don't know.
More reimbursed. Okay.
I don't know.
Sandra,
I was just curious. Thank you.
Yeah, thank you for questioning this question, Dr. Kitamura. I think it seems to be, I've been convinced that Japan is the only communist country in the world. I'm sorry, time is running out. I'm sorry for failure of us to moderate properly, but we have another prominent guest from Malaysia. Can we go next? Okay, guys. So Professor Sharul, it's a University of Malaya. He's another top gun of Southeast Asian countries. Dr. Sharul, did I pronounce properly? That's okay?
Yes, that's correct.
We are looking forward to seeing your slides. I just cut your introduction short, so go ahead and start your excellent presentation, Dr. Sharul.
Thank you very much, Dr. Asai, for and then the JMIC Society for inviting me to give this presentation. I'm truly honored and feel privileged to be able to give this presentation. So I'm just going to talk briefly about the minimally invasive cardiac surgery setting in our country, Malaysia. So I have no disclosure for this presentation. So basically, Malaysia is a country of 33.5 million population. As in, I think most Southeast Asia country, the number one killer, the disease that kill most of our population are ischemic heart disease. And we do still have patients with rheumatic heart disease, which contributes to about 46.7% of tertiary heart center workload. So you can see the orange and the blue color here are all the practicing cardiac center in Malaysia, where we have about 11 centers, which are the government and the university centers. But of all these 11 centers, only 3 centers perform minimally invasive cardiac surgery. And of all the practicing surgeons, which is about 70 surgeons in Malaysia, we only have 4 surgeons who are practicing minimally invasive surgery. So that's how low in terms of minimally invasive procedure being done in Malaysia. So in terms of numbers, the whole country perform about 8,000 procedures per year, probably like no more than 150 cases of MIS procedure being done in the whole country every year. So this is where I work. I work in University Malaya Medical Center. It's the largest tertiary teaching hospital in Malaysia, situated in Kuala Lumpur, Malaysia. So this is our unit. Even though our hospital is a big teaching hospital, but our cardiac unit is quite modest in size. We perform about 450 to 500 cardiothoracic cases. For cardiac cases, we perform about 320 to 350 per year. So in terms of MICS demand in Malaysia, what I can see over the years as a practicing surgeon, I can see that it is increasing in terms of demand. The patient in Malaysia asking for the surgery, mainly because I think a lot of our patient, our population have this fear of surgery. They don't want their sternum to be split open. But the moment you inform that there's another way of doing the operation by not splitting the sternum, they are more receptive in terms of having the surgery. And of course, over the years, with the advance of internet, social media, and of course, word of mouth, the patient becoming more knowledgeable in terms of what procedure that they can have. So I have patients showing me article or clips like, can you do this? Like they have clips from United States, from other countries, and they come to our clinic and asking us that, can you do this? So I'm glad that to offer them that, to say that we can do it. And of course, the cardiologist factor as well. I mean, I can also see that more and more cardiologists, once that their patients that are being referred to us to have as minimal invasive procedure as the patient can have, because they themselves offer a minimal invasive procedure. So they don't want to send a patient to us and have a very like maximal invasiveness procedure. So they want as minimal invasive as the patient can have. So what are the challenges and setting up and maintaining a MICS procedure in Malaysia? Basically, I would say in Malaysia, we have a cost issue. The institution have to invest in quite a large amount of money to set up the MIS center by training the personnel and also buying the instruments, and not to forget about the yearly consumable that they have to buy to maintain the procedure. From the surgeon point of view, I can say that the age is very important when the surgeon take up on this procedure. So in Malaysia, we have a lot of surgeons, like mainly towards the age of retirement. We have not many patients in the middle age group, but we have a lot of newer ones. So because the majority of surgeons are towards the end of their retirement, not a lot of them has got a lot of exposure in MIS, and they don't want to get out of their comfort zone. So hence why our numbers of MIS surgeons are very low in Malaysia. So if we look at this side, a lot of our surgeons in Malaysia, I mean, at least probably in Southeast Asia, want to remain in the comfort zone. But if we look at this other graph here, this picture here, if you remain in the comfort zone, you are basically in the red zone. There's no way that we can learn, we cannot grow. So we need to move out of this comfort zone, the red zone, move into what the surgeon perceive as a red zone, but then that's where you can grow, because that is actually the yellow zone where one can grow and this specialty can evolve. So I would say why the surgeons, majority of surgeons fear remains in the fear zone or don't want to embark into the fear zone, because they're not familiar with operating in a small wound. There are different instruments, different getting used to long shafted instruments can be difficult. It is difficult to set up the cases sometimes, and then there are different suturing and anastomotic technique. And then for CABG, majority of procedure MIS are done beating heart. It's not easy to manage hemodynamic crisis. And of course, if there is complication, it's always quite difficult to manage if one not familiar with the procedure. So in Malaysia, at least we are trying to get our surgeon out of this comfort zone, going into the learning zone by bypassing this fear zone. So there's definitely the learning curve. So what we want to do is to reduce the learning curve. So these are what we are trying to do actively since last year. We've been organizing lab workshop, a dry workshop, and we've been doing live cases in several centers. And here are the example. These are just last year we had our first dry lab where we have MICS, mitral valve and aortic valve total endoscopic workshop. These are all homemade in Malaysia. And then we have the privilege for Dr. Nutapon to help moderate the session. So this was happened last year. where we try to introduce the MIS procedure to the young and also the established surgeon. So, and then we also have live surgery in my center in MMC, and then in Penang, which is another state in Malaysia, which perform in minimally invasive surgery, and also in National Heart Institute. So over the last 2 years, we have MIS aortic valve, mitral valve live cases transmitted by a webcam, and then we have MIS valve intermediate courses. And then of recent years, we started off doing TCRAT surgery, which is total coronary artery right anterior thoracotomy revascularization, which was introduced by Dr. Babiak. So we had one workshop where Dr. Babiak himself came in March, and then just 2 weeks ago, I did another workshop in our hospital in not our hospital, in a neighboring hospital in IJN, Kuala Lumpur. So these are the effort that myself and Dr. Abu Yamin from Penang are doing to stimulate the growth of MIS surgery in Malaysia. So what we hope that with this, that the surgeon will jump off the fear zone and enter the learning zone and hopefully continue to grow in the green zone. So in terms of procedure, we have basically 3 procedures available that we can do MIS surgery: mitral valve, aortic valve, and CABG. Probably in the old days, majority of people will embark on mitral valve and then aortic valve and then CABG. But I think for now, for the newer surgeon or surgeon that have not embarked in MIS, there are procedures that they can choose from. So this is just my opinion that for startup, people need to embark on procedure that can offer a high volume of cases, where every week one can do a case, and also the procedure that have low learning curve. So just briefly from our own experience, we started off with MIS mitral back in 2014. From 2014 to 2022, we have performed about 180 cases. And then to 2015, we started doing MIS CABG using McGinn technique. And thanks to Dr. Kikuchi, he came to visit our center, and we started doing MIS CABG using Dr. Kikuchi technique as well. And then in 2020, we embarked on MIS RAD AVR. And then in November 2022, we started doing TCRAT, which is the Dr. Babiak method. And in a short space of time between November 2022 to May, we've done 51 cases already. So in terms of mini mitral, the journey has been slow but steady. From 2013 to 2017, we performed mainly direct vision, but 2018 to 2022, majority, almost all of our cases were done fully endoscopically. So in terms of which procedure that we want to learn, if we want to embark on MIS procedure, in my opinion, at the moment, because there are majority of procedure that are available, so I feel that people will be more receptive if they start with TCRAT and then moving on to RAD AVR, and after that moving on to mitral. Because at least in Malaysia, these are the type of procedures that can offer a high volume for surgeon to learn the procedure. And also these are the procedure that have a low learning curve. So briefly, I just want to talk about total coronary revascularization anterior thoracotomy. These are procedure which is popularized by Dr. Babiak. So why I find this procedure is attractive? Because it has the perks of MIS surgery by sparing the sternum. But then in principle, it is the procedure use conventional instruments. It can be done by many surgeons. In my opinion, it is very reproducible and it has low learning curve. So if we look between TCRAT and MIS CABG, it is done on an arrested heart, on pump. So it is less technically demanding. In my mind, it will be probably slightly cheaper, and it has high adoption rate, in my opinion. So briefly, I just want to show our TCRAT procedure. So standard left anterior mini thoracotomy, not anterolateral, but anterior mini thoracotomy, where we spare the pectoralis major muscle. And then once we've done that, we started dissecting the IMA, and then we harvest the IMA using harmonic scalpel, skeletonized method. And then again, continuing showing the IMA harbors. And then what this procedure is special in my mind is this sling that was developed by Dr. Bablia. So where he put a sling around the aorta, pulmonary vein, and then IBC to help expose the vessel, so one can perform the procedure like an open PABG. So just briefly, I want to show you how once the patient on bypass, we open the pericardium. See, if you can see here, we mainly use other than the harmonic scalpel, we use mainly conventional instruments. I mean, so it's easy for new centers to embark on. I do use some MIS instruments because we started off with MICS CABG, so we have the conventional instruments. Sorry, the MIS instruments. So we still use them. So here on bypass, we just looking at the vessel that we want to graft. And then first what we do on bypass is we sling the IVC. And then we put a tape around the aorta. So all these tapes help to expose the target structure that we want to perform the procedure. So once we've done that, we will cross-clamp the aorta, and then we use standard blood cardioplegia. And then once we cross-clamp the aorta, in this video here, I show you that we sling the pulmonary vein. So this will aid in the conduct of the operation. So this is the final exposure that what we get once the heart is arrested and utilizing the sling. So you can see here, the PDA is right in front of the wound, about like less than 2 centimeters from the surface. So you can hear, so this is how we expose the PDA. No. Sorry, I'm not sure why this is not playing. Okay, I'll just show you the. I'm sorry why the media cannot play. It was playing earlier. But basically what I'm trying to show here is like by moving the sling in a certain position that one can expose the obtuse marginal, and then one can expose the distal circumflex and anastomose the vessel using conventional instruments on a steel heart. So I try to play this one. So this is where we want to expose the obtuse marginal. So this is a procedure that was performed by Dr. Bablia when he came to our center. So this is the distal circumflex that we can see here. So if you can see here, once the heart is positioned, you can perform the anastomosis without any stress on a steel heart, and the anastomosis can be as accurate as you can do it. Where the distance between the target vessel, target anastomosis to the wound is only about 2 to 3 centimeters. So when we want to graft the LAD, so again we move the sling, and then you can see that by moving the sling, you can get the vessel exposed, and you can do your anastomosis in a relaxed manner. So for proximal anastomosis, I'm not sure why this is not playing. I'm sorry. Okay, I'm very sorry that some of my slide was not working. It was working earlier. But basically here you can see that the aorta is very accessible when we put the side biting clamp. The aorta is very accessible and we can use a conventional instruments to perform the anastomosis. So once all done, we do the standard graft assessment using the transit time flow meter. So basically, in conclusion, I feel that more and more work needed in this region to improve MIS adoption rate. So I personally believe that for a new beginner, for somebody to for us to introduce them to a procedure, it has to be more surgeon friendly, and the procedure has to be not only the surgeon friendly but also for friendly to the anesthetist, friendly to the whole team. So if I can choose a procedure that I want to teach a person, I would choose a TCRAD procedure for somebody who wants to start MIS. Thank you.
Dr. Sharu, also your video was not running, but I think this Dr. Babriak's procedure,
yes,
you can proximize the or object towards your face and it stays still. So you actually did not need video.
Yeah.
It was fantastic.
Yeah, I feel that it's very important that for a procedure because what we want is to improve the adoption rate of the MIS procedure. So
I think you hit a very important point, and minimally invasive not only the technically highly demanding things, just I think adoption, safely adopt is a very important concept, and I think that you hit a very good point.
So
of the mix
for the TCRAD procedure, as I said, I started doing in end of 2022. By this year, I already teaching my specialist doing it already after a few cases, and the person can do it on their own, the full case. So it's very easy to adopt. So I think it's very important that we embark on some procedure that, of course, we want to embark on robotic, total endoscopic, but it's very important not to forget about a procedure where everybody can do.
Your initiative just reflecting the difficulty of a mixed adoption, and that would be one of the topic. I think it's time's running out, but it's briefly, anybody comment? Professor Miyagi, give a few words. Okay. Thank you.
Okay, yeah, thank you.
Dr. Nishi.
May I have one question? I'm very interested in your education and write-up system. And please tell me more detail about your training program or write-up program to adapt the mixed procedure to your country.
So basically, because as I said before, we want to attract surgeons to embark on MIS procedure. So one of the most important thing is for them to get familiarized with the instrument, familiarized with the endoscope. To do a wet lab is quite difficult because of the messiness of the getting the big lab and such. So after looking around in the Europe countries, I feel that dry lab is the easiest way to set up and then to maintain. It's clean and it's easier to. So from last year, we have we made our own box with camera, endoscope camera that you can connect to a laptop or to tablet, and then we bought artificial valve from a company in US, and then get instruments from a company. Then you already set already. So and these are all reusable. So far, in the last less than 1 year, we have performed 4 procedures in our country already utilizing these instruments, and so this will help to stimulate the younger surgeons to embark on this procedure. So when they are, and then of course we need to demonstrate using live cases as well, because no point that we just demonstrate using wet dry lab but never perform it. So we also know a lot of time that day one, they will do a dry lab. Day two, they will see us operating. So this is how they learn, and this is how they get stimulated and want to embark on MIS procedure.
Yeah, thank you very much. I completely agree with you. Maybe so in the future, so your young surgeon will adopt minimally invasive procedures more frequently. Thank you very much.
Thank you.
Thank you, Dr. Nishi. I think one more thing I was impressed is I think it's cardiac surgery is basically, very close discipline is used to be. Now your attitude or your initiative, you're more open-minded. Invite Dr. Babriak from Ukraine and other, you get the training in maybe UK in the summer. And I think these proactive stance really makes your practice or training it more fruitful. We want to continue to communicate with you in our society maybe in the future. And thank you very much for joining us tonight.
Thank you.
Thank you very much.
Thank you.
So time's running out. We've been saying that we finally proudly present Professor Taichi Sakaguchi. He will address his own, not only his own, his Japanese status, minimally invasive cardiac surgery. He's the president of our society. Professor Sakaguchi, please.
Yes, can you see my slide? Can you see my slide? Can you hear me?
Okay, yes.
Okay. I want to thank speakers from each countries for their great presentation today. It was outstanding. And lastly, I'd like to discuss the current status and the future perspective of MICS in Japan. And JMICS originated from the Japan MICS conference in 2000 and was officially established in 2015. The JMICS has 3 missions. The most crucial mission is the safe dissemination of MICS. The first is knowledge sharing. In addition to our annual meeting, we are in the process of developing a nationwide MICS registry to evaluate real-world clinical outcomes and enhance the quality of MICS in Japan. Furthermore, we have implemented certification and mentorship programs to support professional development. And education also plays a vital role. So the second mission is sustainable development by securing incentives to support the continued growth of MICS. Lastly, the third is internationalization, and today's webinar is the first step. So during our annual meetings, we engage in in-depth discussions on various topics. So the number of MICS procedures in Japan has been steadily increasing, and we anticipate further growth, especially since MICS valve surgeries became eligible for government insurance coverage in 2018. According to the most recent registry data, the proportion of MICS in mitral surgery stands at 42%, comparable to Western countries. So we are launching a nationwide MICS registry that includes not only major complications, but also MICS-specific complications such as conversion to sternotomy, unilateral pulmonary edema, and complications related to peripheral access. So by analyzing real-world clinical outcomes, we anticipate an overall improvement in the performance of MICS in Japan. So in addition, we have established a very unique certification and mentoring program to validate the skills and knowledge of MICS surgeons and helps their professional growth. Surgeons with experience in over 100 MICS cases are certified as proctors, providing practical guidance to those studying MICS. Our society also organizes comprehensive training programs, including official textbook and wet dry lab focusing on young surgeons. So in addition to these efforts to enhance the quality of MICS, we are pursuing financial incentives. As a result, mixed valve surgeries now receive a financial incentive of 300,000 yen compared to sternotomy surgeries. So we are currently working towards securing incentives for other procedures such as mixed CABG and specific robotic procedures. As you can see, less invasive approaches have been advancing in every field of cardiovascular surgery. In the remaining time, I would like to discuss a little bit about mixed CABG. So recently, mixed CABG using multiple arterial grafts has become available. It has several benefits, including fast recovery, no risk for external complications, and using multiple grafts, complete revascularization is possible with and without hybrid approach. Also using composite grafts, we do not touch the aorta, which may reduce the stroke risk. So the most challenging part of mixed CABG, of pump mixed CABG, is the displacement of the heart. The heart should be displaced inside the chest. However, in patients with a small chest, often seen in Asian countries, this bulky positioner with a rigid shaft does not work well. So Dr. Kikuchi, he's a moderator, invented a novel positioning technique. He removed the arm of the apical suction positioner. The suction head is attached to the heart and pulled with tape. I use another positioner, the Tentacles Neo. This is made in Japan. Small suction cups with a flexible traction cord can be pulled in any directions. So there are several tips to using this device. Stepwise approach helps the exposure of deep coronary target. So the first suction cup is attached to the heart and the heart is elevated. The second suction cup is pressed in a deeper part and the heart is further elevated. Then the first suction cup was moved to the base of the heart for further elevation. These steps facilitate the exposure of the deep coronary target without compromising hemodynamics. For successful right ITA harvest in mixed CABG, a patient selection is important. I routinely check the chest CT to evaluate the relationship between the sternum and the right ITA. In the left patient, the right ITA is visible from the left thoracotomy, but you shouldn't select the patient with CT finding like the right picture. The right ITA is hidden by the sternum. So do you see the left ITA is here and the right ITA is over there? And when I take the bilateral ITAs, I start the right ITA first. And I usually do not use the endoscope because the right ITA is visible in most cases as long as good exposure is expected by operative CT scan. And to create a composite graft, the right ITA is pulled out through a small incision in the right second intercostal space and extended with the radial artery graft. It is reintroduced into the chest and used as a sequential graft for the lateral and the posterior wall. So the maybe I have to finish my presentations. And once again, I'd like to express my gratitude for your participation today. And JMICS has plans to organize more international webinars in the near future. In today's webinar, we had each country's mixed situation explained, and we would like to plan future webinars focusing on the different topics. If you know of a surgeon doing something interesting or would like us to plan something, please contact us using this link. There are over 40 countries in Asia, and we hope to communicate with as many Asian friends as possible through the JMICS webinars to foster mutual development. Thank you Thank you, everybody. Thank you.
Dr. Sakaguchi, thank you very much for.
Yeah, thank you.
Kikuchi, Dr. Kikuchi.
Yes. Thank you. Thank you very much.
We finally came to the end, but this is
Yeah.
just the beginning of our JMix challenge.
Yes, yeah.
Dr. Sakaguchi.
Yes.
We would like to focus other more deep aspect of each valve surgery, coronary revascularization, other aspects of congenital, more and more coming on. I think that's Dr. Sakaguchi's message. And we are aiming for, probably Dr. Sakaguchi will tell us, we are aiming for the convene the workshop of JmicsWebinar again in Japan few years later, 2 years later. It's Dr.
I think.
Yes, and I think we won't have your, I think, support, and we really, I think, grateful to all participants of this time the webinar, and we want to make this event more exciting and interesting in the second time, right? So I think it's a final comment to be, I think it's addressed by President again.
Okay, so thank you the participant in this event, and I think this is time we come together because the COVID is over. So we are very looking forward to seeing you guys soon. Thank you. So
thank you.
Thank you very much.
Mr. Pong,
yeah.
Dr. Sham.
See you again.
Thank you so much. Sawadee krap.
Thank you much.
Thank you, everybody. Bye-bye.